So hello, everybody. Thank you for coming tonight. I know we were supposed to be at the Ridgewood Library, and then there were quite a few people that were going to join us virtually. I think the Ridgewood parking lot at the library is underwater. So we are here. I am in my office. I'll tell you a little bit about myself. I have been a midwife in practice for just under 30 years. I am in this age demographic myself. So that perimenopausal, menopausal age demographic. I am with you, and I am assuming that that is who is attending tonight. I do love in-person presentations because I get to know my audience really, really well. But since this is the climate in which we're living in the middle of a pandemic, we're going to do this as best we can. So I am a practicing midwife for almost 30 years. I have a degree from Duke University. I did my doctoral work at Duke, and I have another graduate degree from the University of Pennsylvania. And I did a fellowship in integrative medicine at the University of Arizona. So my I usually come more from like a functional medicine, integrative medicine lens. That's where I have spent most of my time. I was trained by a brilliant physician by the name of Andrew Weil, who you may have read some of his books. He's a Harvard trained physician, brilliant, believes in conventional medicine, but also integrative medicine, sort of collaboratively working together. So tonight we're going to talk about everything that we can in an hour with perimenopause and menopause. I will tell you to start this program that any products that I mention or medications that I mention, I have absolutely no affiliation. That's a non-disclosure for you. I don't affiliate with any drug companies. So if I bring things up, it's really just through my own experience, and I'm happy to answer any questions at the end. So we're going to go ahead and get started. As I said, I am a nurse midwife, and so I think most people find babies pretty adorable. I do throw them in most of my lectures, no matter what I'm lecturing about. So just to get started, right? Here's this little baby. What happens to me in 40 years? Oh my goodness, look at that sweet face. So here we go, right? Let's talk about it, right? Because menopause is fun, said no woman ever in the history of women. So what is it? Right? What exactly is menopause? Well, it's a very normal, naturally occurring event, pretty much defined as the final menstrual period or the last menstrual period confirmed after one full year of no bleeding. So what does that mean? That means that if you've been skipping periods, maybe 3, 4, 5 periods, are you menopausal? Absolutely not. You're not considered menopausal until you've had 12 full months of no periods. If you go 11 months no period and then you start bleeding, you're not menopausal yet. You start counting over again. So until you've had 12 full months of no period, you're still in that perimenopausal phase, that phase of life where your periods are still happening. So until you've had a full year of no periods, you're not considered menopausal. But essentially what it does is it represents like the absolute stoppage or permanent cessation of your period, right? And why does that happen? It happens because your ovaries are no longer working, right? They don't produce any follicles, they don't ovulate anymore, and it's usually due to aging. Certainly there are other circumstances, right, that can cause your ovaries not to work. That can be medication induced, surgically induced. If somebody has a hysterectomy, they'll go through surgical menopause. But when does it normally happen on a natural occurring basis? Normally, spontaneously for women, somewhere around age 51. Now, I have two patients right now in their late 50s. One's 58 and one's 59, and they are still getting regular periods, and they are very unhappy about that. But it can happen anytime, from generally, in the mid 40s until the mid 50s, with the average age being about 51. So if there's medical intervention, somebody has their ovaries removed because of an ovarian cancer, for example, or if somebody has loss of ovarian function because of chemotherapy, they can then have sort of medically induced menopause. And then any time from ovarian, impaired ovarian function. So there are people that have premature menopause, that might be in their late 30s, early 40s, their ovaries no longer work for a medical reason or otherwise, and those people would be menopausal, but it would be considered premature menopause. So just to give you an idea of when it happens, generally the early 50s. So what happens to our bodies? And if you're in your 40s, you're going to start saying, hey, that's happening to me right now. Like I'm not menopausal, I'm still getting periods, but this may be happening to you right now. We're going to talk about that as well. So the classic symptoms for, early menopause, perimenopause, is a very distinct change in the bleeding pattern, your menstrual pattern. So generally women will start saying, I'm having longer cycles, like more weeks in between my cycles, or they may shorten a little bit too. You could have cycles, every 21 days, or they could be every 60 days, or you might get a period and then not get another one for a couple of months, and then you bleed again. The first thing that brings women into my office anyway is when they start saying something's wrong with my period. And it's a little bit of a red light, or sort of a bright light moment when I say, listen, it's not necessarily that something's wrong. Sometimes this is just the natural course of events as we age. Nobody likes that answer. It's like when somebody says, oh, your eyes are quite good for your age. I always tell somebody, don't ever say for my age. I don't want to hear that, right? It's hard. It's a hard pill to swallow. The other thing that tends to happen quite frequently that brings somebody into my office is, you start to have what's called vasomotor symptoms. So hot flashes, night sweats. And then as you start to get post menopause, like past, you haven't had a period for, at least a year. And now we're talking 2 or 3 years past that, we start to get what are called vulvovaginal symptoms, where people will say, I have a lot of vaginal dryness, or intercourse is quite painful for me, or I feel like I'm irritated. I think I have a yeast infection, when in fact, it's not a yeast infection at all. It's actually just the effects of a lack of estrogen on the vagina itself. So you can start to feel like you're thinking about your vagina. That's how I describe it to everybody. Like you're thinking about your vagina more than you think you should be thinking about it. If that is happening to you and you are a couple years past your period stopping, the likelihood is that you're having vulvovaginal symptoms. You're just noticing the effect of a lack of estrogen on the tissue in the vagina. So that's actually quite common. So other things that are sometimes associated with menopause are, having difficulty sleeping, or having no trouble falling asleep, but then waking up several hours later and your brain just cannot get off what I call the hamster wheel of thinking. You're thinking, you can't fall back to sleep. That's actually quite common, a common complaint. Sometimes people will say, I feel like brain fog, like I can't remember things. So a little bit of a lack of concentration, some foggy thinking. And then also, and a little bit more extreme, sometimes people will say, I've never had anxiety. I never felt depressed in my entire life. And all of a sudden, I just don't have the same vigor for life, or I find myself very anxious all the time. So, these are the moodiness, like the crankiness, can kind of increase through perimenopause and through the menopausal phase of life. So I love this slide. I always say, can you relate? I certainly can. And it's appropriate for the season, right? The 7 witches of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho, right? And I can tell you just from my own experience, I've been every single one of these on any given day, and sometimes a combination of them. So if that is how you feel, then this lecture is for you for sure. So let's talk a little bit about terminology, menopause versus perimenopause. So perimenopause is considered the time around the menopause, right? Also called like the transition. So the time frame leading up to menopause itself. And it is generally the most symptomatic phase for women. So most women, between like early 40s, right, to early 50s. 41, 42, all the way up to like 51, 52, 53, until your periods are gone now for over a year, is most often the time when people come in saying, I don't even know who I am in my own body. I am constantly irritable. I can't stand my husband on most days, or my partner on most days. That is not me. I'm yelling at my children. I hear it all day, every day. So I know that these are common symptoms. I certainly, feel them myself. So I know that it can be really, really, it can really change the way that you look at life. Life is not as fun when you're going through perimenopause, but there are definitely ways to treat that. So we'll talk about that as well. So very briefly, I want to just, go over the terminology. Induced menopause is essentially your period stops after either having your ovaries removed surgically, right, with or without hysterectomy, or if you've had chemotherapy from a different type of cancer, or radiation therapy, which is also called iatrogenic menopause. So simply your ovaries are no longer functioning because of some sort of other process. So premature menopause, any menopause that happens before age 40, that's essentially considered premature menopause. So, ovarian insufficiency is a little bit different. Sometimes women will come into my office and they'll say, I was told I have ovarian insufficiency. And what that just means is your ovarian function is impaired, right? Your ovaries aren't working the way that they should be working, and you're under age 40. So it's a little bit different, ovarian insufficiency and perimenopause. All right. And then postmenopause essentially is the years that are after 12 months of no period. So you don't get your period for 12 full months, you're menopausal. And then those years following that time frame, you're considered postmenopause. So when you think of what current life expectancy is in the United States, which is 82, for most women, that's the average life expectancy of a woman right now in 2021. You're going to spend somewhere between a third to a half of your life in a postmenopausal state. So we really need to kind of learn how to live in that state and still be comfortable and function and thrive, right? We want to be the best and the most healthy that we can be in those years without our period. And I think the common thinking is that we are only adequate women prior to menopause. And I know many, many, many women who would say, my gosh, I feel like my life started again after menopause. So a little bit of a mindset shift and a little bit about knowing how to manage the symptoms. So let's talk about like the clinical approach. What happens? So lighter bleeding, heavier bleeding, your bleeding can last for a longer period of time. Your cycle length may change. It can be a little bit shorter to a little bit longer between periods, and you can skip periods. All of those things are considered completely normal. So here's what's not normal. This is what you have to kind of know that could be a red flag and you'll need to see your healthcare provider for. If you have heavy bleeding through your clothes, most women in their 40s will go through a period of time where they will spot for a couple days. They'll get very, very heavy bleeding with clots sometimes, and then it'll taper off with a little bit of spotting again. If you are soaking through your clothes, or you are changing your tampons or your pads more than once an hour, that is considered heavy bleeding. Here on this slide, they quantify it in terms of milliliters, but let's be honest, none of us are, putting our menstrual blood in a cup and measuring how much that is. So the generally accepted rule is if you're changing a super tampon or a maxi pad, more than once an hour, that is heavy bleeding, right? So if you have menstrual bleeding that lasts for more than 7 days, or 2 days longer than what your normal menstrual flow is, that can be considered abnormal uterine bleeding. I'm not saying that it always means that something abnormal is going on. I'm saying that would be an indication to check in with your healthcare provider. If you have periods that are less than 21 days apart, my tolerance is actually 23 days. The clinical definition is less than 21 days apart from the beginning of one to the beginning of the other. That may indicate that you're bleeding a little bit too frequently, and there is some follow-up testing that your provider would want to do with you if that should happen. So you'd want to check in with your healthcare provider if that's happening. If you have spotting in between periods, usually warrants a phone call just to kind of check in. It's almost always normal, but it is a reason to call. And if you have consistent bleeding after sexual intercourse, here or there, once in a while, totally normal. But if consistently you're bleeding after each act of intercourse, you definitely want to check in with your provider. So let's talk again about those vasomotor symptoms. So episodes of what's called, flushing or hot flashes. And women who get these know exactly what I'm talking about. Literally starts from, your core and works its way up, this intense feeling of heat that just kind of works its way up. And some women will get very, very red and become sweaty, and nobody else in the room is looking the same as you are. And this is your own private summer that's happening. It can be really bothersome for a lot of women and really impact, where you go or how you dress or how you live your life. So can be really a nuisance. Most women who are perimenopausal, at least in the US, because of because of our diets and, how we live our lives. Most women, about to 75%, will get some sort of what we call menopausal flushing or hot flashes. And they're just triggered by, very small increases in body temperature. Your core body temperature just very quickly sort of starts to rise. And treatment is sort of based on how does it impact your life. If it's just here or there, doesn't really bother you all that much, you can kind of fan yourself and kind of move on, not a problem. But if it's really impacting your life or your work or your relationships, then it does warrant some sort of treatment. Just a quick illustration of what it feels like, right? For most women, you look at the picture on the very far left, and you'll see like core body temperature starts to increase, your heart rate starts to increase a little bit, your skin blood flow starts to increase, and it increases rapidly. And then you start to feel the heat. So that's that second picture. And then it starts very slowly to come down. And then some women will get chills at the very end of a hot flash. So it's a very sort of uncomfortable feeling to go from normal body temperature to very hot to very cold in a short period of time, minutes actually. Let's talk about the vaginal symptoms, because this is almost always what brings people into the office. So vaginal dryness, irritation and itching. Dyspareunia just means painful intercourse, right? And it happens up to 50% of the women who go through menopause will have symptoms. Some women don't talk about it, or they feel like they don't feel comfortable talking to their provider about it. But because it's so common, I hear this every day. So it's something that you really do want to speak to your healthcare provider about. We expect, these complaints. So we can give you suggestions on how to treat. And we're going to talk about that a little bit more in a few minutes. But, my point here, the take home point is never be afraid to bring up these topics to your healthcare provider. That's what we're trained to do, right? We're trying to help you. So if you're having painful intercourse, or if you feel irritable in the vaginal area, make sure that you, just give a shout out to your healthcare provider and tell them, this is how I'm feeling. Do I need to come in for a visit, or is this something we can discuss on the phone? We really want to make sure that we are addressing, your issues. So when vasomotor symptoms, hot flashes, night sweats, those types of things generally get better over time, but the vaginal symptoms actually can worsen over time. The thing about the vagina is it's kind of like a use it or lose it type of an organ. So if you are not having intercourse regularly, over time, the tissue in the vagina will thin out and not have as much elasticity, so that if you do engage in intercourse, even periodically, it starts to become very, very painful. I've had people say, even so much as it feels like there's razor blades going into my vagina. I've actually heard those words, it explained in that way. So that's never a comfortable thought, right? So these are things that we want to make sure that we treat if that's what you're feeling. So regular sexual activity helps. Lubricants, just things you can get over the counter. Astroglide is an over the counter lubricant that sort of most mimics your own natural lubrication. It doesn't feel very commercial in terms of its feel. It's not sort of rubbery. It's actually more water-based. So Astroglide, I oftentimes recommend to my patients. There are products over the counter that can be used. Replens is another one, which is something that you need to use ongoing as it's directed on the box. It is not estrogen, but it sort of acts like estrogen acts in your body without providing any risk. So it's something that you could use ongoing as it says on the package insert. And it's an applicator. You put the cream in the vagina and you use it ongoing on a weekly basis. And that can sometimes help to restore some vaginal moisture and make intercourse more comfortable, or take down some of the irritation that most women feel post-menopause. And then working its way all the way up to localized vaginal estrogen, which would actually be, estrogen that's inserted into the vagina on a very regular basis, that sort of restores that elasticity, brings back that elasticity, makes intercourse much more comfortable. There's also a company called Bonafide, and the website is hellobonafide.com. So a great website that sells natural products. So if somebody's afraid of using estrogen because they are concerned about risks, and we'll talk about that in a second, but they want to try something natural to try to address hot flashes or to try to address vaginal dryness, that company, hellobonafide.com, you can't get it on Amazon. You can't get it in Walgreens or CVS. You have to order it directly from the company. But there are natural solutions to most of the menopausal symptoms that women feel. So that's a great resource for you if you're looking for sort of a natural alternative solution. I use their products quite frequently. So you might want to check that out. So let's just look at what happens with the vagina. So if you look at this little picture on the left, this is a well estrogenized vagina. You can see the sort of elasticity, that nice up and down of the cells. And then if you look to the right, as estrogen production decreases, the tissue actually starts to get much thinner and less elastic. So that's essentially what it looks like, what's happening in your body, premenopause versus postmenopause. So when we talk about sexual health, we see women as with increasing age start to say, at the midlife point, 45 to 65, I would say, start to complain about, painful intercourse or low libido, which is a big one, right? Low libido, which I would say to you is multifactorial. So low libido, we cannot blame 100% on perimenopause or even menopause, because there's a lot of women post-menopause where their libido now peaks and it increases. So why is that? So studies tell us that when women age, right, and they're done with their periods, what happens? They're also usually at a phase of their life where their children are grown. So the stress of raising children are gone. They are no longer rushing around from place to place to place, work to kids' activities to, PTA meetings or whatever. So their stress level actually decreases. And there's oftentimes a reconnection with their partner. So in so much that women post-menopause sometimes say there's like a little bit of a sexual awakening, it also stands to reason that when we are in the most hurried, active times of our lives, working, raising children, taking care of elderly parents, that maybe sex starts to fall a little bit lower on the list of things that we really feel like doing, right? So I always say to my patients, like sleep, sex, right? Sleep, sex, sleep, sex, sleep, sex, right? That's usually how it happens when women are raising younger children. And now with women oftentimes delaying childbearing till their mid to late 30s, we are raising children well into our 40s and 50s. So, low libido, which is a common complaint, I hear it all the time, every day, is not always decreased testosterone levels or perimenopausal. So yes, is it common? It is, but you have to kind of keep in mind that it is quite a multifactorial issue, and it's important to kind of go through all the layers of what causes low libido with your healthcare provider to try to be able to figure out a path to treatment. So when we talk about decreased estrogen, that's decreased elasticity in the vagina. We know that in the perimenopausal and menopausal phase of life, like testosterone levels start to drop a little bit. So that can be one of the things that causes low libido, but not 100%. And then if you have an active sex life, you oftentimes don't need moisturizers and lubricants as often as if sex becomes a little bit more infrequent. So I always tell women who are in their 40s, you really should have a lubricant at the bedside. Just have it in a drawer in case you need it, just to kind of help maintain vaginal health. Sleep disturbances are a big one. So we know that perimenopausal and menopausal women sleep less. They have more frequent insomnia, and they're more likely to use prescription sleeping aids. So this says perceived decline. I will tell you, as somebody who is in this age demographic, it is not a perceived decline. It is 100% an actual decline in how much you sleep, usually in your 40s and 50s. So, people, as we age, we have less estrogen. We have to get up more times to go to the bathroom. So if you're not somebody who falls asleep right away after using the bathroom, then you've interrupted your sleep. Things like sleep apnea, depression can fall into the category of why people might sleep less. any type of stress can affect your sleep. And then obviously ovarian hormone changes. Now here's where, my integrative lens starts to come into play. So there are some really, really good things that you can do to try to, help sleep quality. There's some great teas that are available. So the things that help people sleep: passion flower, valerian, melatonin, chamomile, lavender, lemon balm, all of those are great sort of sleep aids that you can use, a little cup of tea right before you go to sleep. I always tell everybody you want to steep the tea bag, not like dip, 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 throw the bag out. You want to steep that tea bag for a good like 4 to 6 minutes to get a good medicinal effect. Traditional medicinals makes a great tea that's called Nighty Night. I think Celestial Seasonings makes a sleepy time tea. So any of the sort of nighttime teas are oftentimes very helpful. There's also a product that is called GABA Calm, CALM. It's made by a company called Source Naturals that is great for like nighttime waking. When you wake up in the middle of the night, you can't quite fall back to sleep. Now, if you take any antidepressant medications or any anti-anxiety medications, you would want to check with your healthcare provider before using a product like GABA Calm. That's important disclosure there. You need to know that. But if you don't take any medications, you wake up in the middle of the night, your mind is racing. Source Naturals GABA Calm, great product, something to sort of kind of help. And then I also love the idea of meditation and sort of there's a great, let me think. There's a really, really good sleep talk. I call them sleep talk downs. If you have a set of AirPods or you have headphones that you can use and you have access to YouTube, there is a great hypnotist. His name is Jason Stevenson, and it's Stevenson with a PH, Stephenson, Jason Stevenson. If you go to YouTube and you type in Jason Stevenson, you are going to see just tens over tens over tens of different sort of meditations that he does that are unbelievably helpful to A, fall asleep, and B, stay asleep. He has sleep meditations for anxiety, sleep meditations for, I don't know, stress, sleep meditations to help you fall asleep. And some of his are an hour, some of them are 45 minutes, some of them are 10 hours long. That's where if you have AirPods in, it's really helpful. I usually just pop it in on my phone, put my phone down in one of my bedside drawers and leave it alone, and I am asleep. And oftentimes I will stay asleep all night long. So keep that in mind. Jason Stevenson, he does some great talk downs. They're called sleep talk downs, but if you just pop his name in, you will you'll get to him. So think about, hot flashes, how hot flashes can impact, your sleep. It just triggers you waking up all of a sudden. Night sweats, you're sweating. It's like right after you have a baby, the first 2 or 3 months after you have a baby, you can wake up just having to change your clothes because why is that happening? It's because this is what's happening to your hormones, right? So that's what happens during perimenopause and menopause as well. You don't have that steady state balance of estrogen and progesterone. So you can wake up in the middle of the night with hot flashes, and then all of a sudden you're freezing, you're hot, you're cold. So that can really disrupt sleep. So the decision on, when to treat, how to treat, what to treat becomes a very distinct conversation with you and your healthcare provider. So how bad are your symptoms? Like, is it distressing or is it life stress, right? Is it happening during the day? And then what to do if you're having those types of symptoms. So if you're also starting to then notice like brain fog, cognitive changes, you can't quite remember things as well as you think you used to, right? I always walk around the house with my keys in my hand sometimes, and I say, where are my keys, right? Right in my hands. So it happens to all of us. So look, there's several things that I usually recommend to my patients when people are starting to complain about brain fogginess. CoQ10 is a great supplement that helps increase blood flow to the brain. So I use CoQ10 oftentimes for that. I use 100 milligrams twice a day for my patients that are having brain fog. Great option to sort of try, knowing that every supplement that you try, you need to use for at least 6 weeks to 2 months before you're going to notice any type of an effect. And again, my lens is a functional medicine, integrative medicine lens. A conventional obstetrician gynecologist will say I don't believe in that. That doesn't work. Supplements don't work. I don't necessarily subscribe to that philosophy. I do think that supplements work in the right context. So that is something that I often use for cognitive changes. So, mood disorders, when you start you feel out of control, irritable, fatigue, feeling like bluesy all the time, can't quite understand like what's happening to yourself, that can be caused by fluctuating hormone levels, sort of the ups and downs of your hormones. And if you have a history of PMS, premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, you are more likely or more vulnerable, right, to having these sort of, mood changes. So what's helpful? Exercise is super helpful. Again, I'm coming through my functional medicine, lens. I don't always think that, using a prescription medication is the only way to treat these kind of symptoms. So, with healthy diet and adequate exercise, oftentimes people can feel, 75 to 80% better. I tell my patients, I can't make you feel like you did when you were 20. You're not 20 anymore. But can I get you to a point oftentimes where you're feeling like you feel a little bit more like yourself again? Yeah, oftentimes that can happen, but it does require a little bit of lifestyle change, right? We have to be willing to put the work in. Anything that's worth it is worth working towards. The other thing that can sometimes contribute to some mood disorders, and I know some of you will argue with me, and hot flashes, is how much alcohol we're drinking. So I know so many women who will come to see me, and when I try to take back a little bit of their alcohol use, they're like, no, give me something else. I am not giving up my wine, right? Like, we're raising teenage kids. We're like this with the bottle. So, just know alcohol use can contribute to your hot flashes. Alcohol use can contribute to your sleep disturbance. It may make you fall asleep faster, but it generally will not keep you asleep. So these are things that you kind of have to know, might have to shift a little bit. So the most predictive factor for depression at this age frame, 45 to 65, is if you have a prior history, or if you've had a history of postpartum depression. Even you're more likely to have depression at midlife, because we're talking about wild changes in your hormones. So when we talk about relaxation and stress reduction techniques, that's that Jason Stevenson that I was talking about, that YouTube channel, amazing sleep talk downs, meditations, guided meditations. There's the app, the Calm app you can put on your phone. There's an app called Headspace that can be really helpful. 5-minute meditations. I have a couple sleep apps on my phone that I use oftentimes that just have, kind of calming nature sounds or ocean sounds. But I always find the ones that are the most helpful are the ones that are guided meditations, actually talking through. That's why I love that Jason Stevenson, and I recommend that to many of my patients. So, then we have, counseling, psychotherapy, and medications, depending on the duration and the severity of your symptoms. So let's talk about urinary symptoms, because this is really, really common when people come in, and oftentimes the thought process is, I have a urinary tract infection. I know I have a urinary tract infection because I'm getting up a lot of times at night, or I know I have a urinary tract infection because I have to go to the bathroom more frequently. But it's really common. I mean, I love this slide. I think it's, cute. I've reached that age where I've given up mind over matter, and now I'm concentrating on mind over bladder. So women at midlife, do urinate more frequently. We have a harder time kind of holding our urine. oftentimes there can be a little bit of urine leakage, urinary incontinence, all very common symptoms. And this is the number one thing that women do not want to talk about. Women want to talk about their low libido. They do not want to talk about if they are losing urine when they cough or sneeze or exercise. It's really important to be able to have that conversation with your healthcare provider, right? So over half of women over age 50 are going to have some sort of urinary incontinence. Like, this is stuff that is really, really common. So mild incontinence usually happens after we give birth to our babies, right? And in the first 5 years after menopause. So for a very long time, there can be mild incontinence symptoms. So something as simple as Kegel exercises, I'm sure you've heard of them. Actually, those are the muscles that you use to stop the flow of urine. Is very helpful in being able to control mild incontinence. But when you start to get to a point where you're losing quite a bit of urine, or you feel like you have to go to the bathroom and you can't quite make it there, the urine starts coming out before you actually get seated on the toilet, that usually gets to the point where it's more moderate to severe incontinence. And I usually recommend for our patients that we use a pelvic floor therapist. A lot of women don't even know that this is a subspecialty of physical therapy, but pelvic floor therapy is immensely helpful. It does not always have to be a surgical fix for bladder incontinence. So pelvic floor therapists, and there are lots of them. As a matter of fact, within Valley Health System, we do have a pelvic floor therapist on staff. She's amazing. Her name is Justine Ward. She's phenomenal. And she helps so many women sort of start to learn all of the muscles within the pelvic floor, how to control that musculature, and with simple things like postural changes or slight changes in the exercises that you might do to be able to support the pelvic floor so that it supports the bladder, more readily. And a pelvic floor therapy referral, you can self-refer for pelvic floor therapy oftentimes, depending on your insurance. It's an evaluation in a room by yourself with a pelvic floor therapist who is skilled in all the treatments that require not just regular physical therapy, but the pelvic floor specialty. And then usually they'll sit down with you after their exam. It's a very thorough exam. And, he or she will say to you, it's almost always a woman. As a matter of fact, I don't know any male pelvic floor therapists. If I'm being really honest, it's almost always women. So she'll say to you oftentimes, listen, I think I can make you 75 to 80% better in X number of visits. So, if it's covered by your insurance, I would tell you, even if it's not covered by your insurance, it's something you might want to think about. Wildly helpful before you consider a surgical option. I think the surgical option, a bladder sling, that's oftentimes spoken about quite frequently. And I do think that if you haven't tried pelvic floor therapy first, that a bladder sling is a little bit aggressive. There are certain conditions where a bladder sling is 100% appropriate, where pelvic floor therapy won't help you. But pelvic floor therapy is extraordinarily helpful. I recommend it to almost all my clients. Let me go back to that slide for a second because I want to address something. But I do recommend pelvic floor therapy to almost all my clients. So let's talk about like foods to avoid. The foods that we know can cause sort of overactive bladder, or OAB. You may have heard that. And while there are medications that are used to treat overactive bladder, there are certainly foods that can aggravate the bladder or give you symptoms more readily. And those things are anything with carbonation. So your seltzer waters, your sodas, your diet sodas, anything with caffeine in it. And I don't really know too many women in their 40s and 50s who operate without caffeine, right? We all feel like we need caffeine to keep us going from one day to the next, but it definitely affects bladder function. So trying to cut down on the amount of caffeine that you drink can sometimes help those urinary symptoms. Anything that has chocolate in it, because chocolate contains caffeine, that can, right? I know what you're saying. I don't care. I'll leak a little bit. I want my chocolate. But it does, like, just in all seriousness, chocolate definitely does increase bladder symptoms. Alcohol can increase your bladder symptoms. Citrus fruits, believe it or not. So a lot of times if you remove citrus fruits from your diet and you have overactive bladder, you'll find that your symptoms improve. And then anything that is tomato based. So tomatoes, salsa, ketchup, any of those foods can also irritate the bladder and give you those symptoms, like you feel like you have to use the bathroom more frequently. So really briefly, I just want to touch on osteoporosis because it's a common concern of women who are menopausal and postmenopause. It is, compromised bone strength, essentially, usually diagnosed by something called the DEXA scan, which is an X-ray of your bones. Usually DEXA scans start somewhere between ages 50 and 60, depending on risk factors, and are repeated either yearly or every 2 years, depending on what course of treatment your provider is choosing for you. So it does increase the risk of fracturing a hip or a femur, right, which is your leg bone. So bone health is really important. So when we look at menopause, lower estrogen effect in our body, it does, lower estrogen accounts for about 2/3 of our bone loss during those 5 to 7 years around menopause. So when we're looking, there are definitely specific things, and I don't really want to get into it. It's on the slide, what a DEXA scan or a bone density scan would show. But here's what you need to know. In your younger years, right, 30s, early 40s, well into your 50s and 60s, weight bearing exercise is by far the most important thing that you can do to protect your bones. If you have strong muscles around your bones, even if your bones are a little bit weaker, those muscles are going to help to protect bones that are thinning. So what's weight bearing exercise? Walking is the easiest, most inexpensive weight bearing exercise that you can do. Strength training is weight bearing. People will say, what about swimming? That's not weight bearing. You're weightless in the water. So something that's going to make you actually use your muscles to strengthen your bones is considered weight bearing exercise. That is, I tell my patients, the number one thing. If I could tell anybody, one thing that they can do to improve their health, I would tell you to move your body. Right? Move your body a little bit every day and work up to the point where you are moving your body almost, 6 to 7 days a week. All right. So here are your risk factors for osteoporosis. Over age 50, if you have a parental history, if you are female, if you smoke, if you are of lower weight, shorter stature rather, meaning a little bit shorter, these are all your osteoporosis risk factors. So management depends on your symptoms. Management depends on a bone density score and what you're willing to do, right? Or do you want to just do supplements? Do you want to use medication? And, a conversation with your healthcare provider. All right, cardiovascular disease, another thing that we have to think about in the menopausal phase of life. So, coronary heart disease, coronary artery disease, stroke, second leading cause of death for women. And also we're starting to see it in younger women, right? And for the first time in 4 decades, we are seeing an increasing risk of coronary heart disease in women due to obesity, diabetes, hypertension. So what do? How do we, lower our cholesterol? How do we make ourselves, aware of what we're putting in our mouths, right? Because our weights are starting to go up, 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 as the decades have sort of passed, the last 4 decades. And so we really want to make sure that we are doing the best thing that we can nutritionally for our body. So we move our body and we're careful. We're careful about what we eat. Here are the diets that I recommend for people. So this one's called the DASH diet, and what it stands for is dietary approaches to stop hypertension. And they're like food pyramids. This is stuff that you can look up, right? Grains, fresh fruits and vegetables, lean proteins, low-fat dairy, right? This is a great diet if you are someone who has high blood pressure. Take some time, look it up. There's the Mediterranean diet, another great one, right? Again, and they're very similar with just slight differences. So, looking at eating red meats sparingly, lean proteins, fish, seafood, whole grains. Again, this Mediterranean diet and physical activity. And then there is my favorite, which is an anti-inflammatory diet. So this one is put out by Andrew Weil, who I trained under. This is one that I talk to my patients about, which actually incorporates, healthy sweets like dark chocolate, which is extraordinarily healthy. Milk chocolate, not so much. Talks about supplements, a little bit of red wine. So it kind of throws in all the stuff that I think people really enjoy. And then, we start to look at what are the foods that help to decrease inflammation in your body. Inflammation in your body increases your risk for coronary heart disease. diabetes, high blood pressure. So, autoimmune disease. So we really want to try to decrease the amount of inflammation in our body. So also, I want to talk about, cancer, because I always hear menopausal women say, I don't want to get cancer. But menopause is not associated with an increased cancer risk. Cancer risk increases with age. And so I think the thought process is that it actually is associated with menopause, but it's actually not. So what are the recommendations, right? Here are the most recent recommendations for screenings. Breast cancer, once you hit age 50, mammograms every 2 years. Prior to that, mammograms starting, American Cancer Society says mammogram should start at age 40. American College of OBGYN says a screening mammogram between age 35 and 40. And then starting yearly at 40. So every 2 years starting at 50. Colonoscopy every 10 years, right? Depending on your risk factors, beginning at age 50. Screening tests for endometrial cancers, that would happen with any postmenopausal bleeding. So any bleeding postmenopause, you want to talk to your healthcare provider about. And then ovarian cancer, which everybody asks me all the time, what can I do to prevent ovarian cancer? There's no screening test for ovarian cancer, but attention to symptoms, right? Bloating, pelvic pain, sudden onset of urinary urgency that's not related to a urinary tract infection, those require reporting to your healthcare provider. Cervical cancer. Now, these guidelines change. They've changed quite a bit. So now it is a Pap test every 3 years or every 5 years if it's combined with an HPV test after a normal report 3 years in a row for women ages 50 to 64. Now, prior to that, if you've had a LEAP procedure because you've had a significantly abnormal Pap smears are still being done yearly. There are a lot of providers that still do Paps yearly, but it's actually not the recommendation. Now it's every 3 to 5 years. And some of your history is dependent on that. So you might want to bring that up with your healthcare provider. Can I go to an every 3-year Pap? Or an every 5-year Pap based on history. If you're switching sex partners, right? If you are divorced and dating, then my patients who are divorced and dating, I do Paps a little bit more frequently because cervical cancer is, very much related to sexual activity and the number of sexual partners that you have. That's important to know too. If you are over age 65 with 3 or more normal Pap tests in a row, you've had no abnormal Pap in the past 10 years, and you've had 2 or more negative HPV tests in the past 10 years, you don't need a Pap ever again. So how beautiful is that? Because the risk for cervical cancer is so low in that population. All right, so management for menopausal symptoms, hormone therapy, right? It's what everybody wants to talk about. So hormone therapy, estrogen progesterone therapy, bioidentical hormone therapy. So what's the difference? Estrogen progesterone therapy can be done through a prescription through a pharmaceutical company, or it can be compounded to what's considered bioidentical, which in essence, means that it is identical to the estrogen and progesterone that we have in our body. Not all obstetricians, gynecologists believe in bioidentical hormones. They only believe in conventional hormones. So it's important to kind of have that discussion with your healthcare provider. If it looks like you want to take like a more natural approach, like a bioidentical hormone. Now, here's the caveat. If you look at studies in the US, and this is most conventional gynecologists will tell you, the risk for cancer if you use hormone therapy is the same no matter what kind of hormones you use. Conventional hormones prescribed from a pharmaceutical company versus hormones that are compounded. Now, if you look at some of the European studies, they don't say that. They actually say that bioidentical hormones may be safer, but we don't have a lot of studies in the US on bioidentical hormones. And, my bias would probably say because they don't make as much money. So it's a matter of, which direction do you go? Do you stick with just the science that exists in the United States? And if the answer to your question is yes, then you probably go a conventional method. Now, there are a few bioidentical hormones that are made by pharmaceutical companies, and they're well regulated. So a lot of my patients who come to me and they want bioidentical hormones, we go in that direction oftentimes. And then I use compounded hormones for people that sort of have different circumstances where we need to sort of taper and tailor their treatment. So there is, hormone therapy, I think, is extraordinarily helpful for many, many, many women. So the general idea is you use hormone therapy for the shortest amount of time necessary to control symptoms. It's a really important conversation to have, with your healthcare provider. So what are the risks? The risks are low, right? So we need to know that the risks are low, but they can include an increased risk for blood clots, an increased risk for stroke, increased risk for cardiovascular events, which can be heart attack. So you need to know that, right? If we're using localized estrogen in the vagina, the risks are then a little bit lower even. So estrogen therapy in the vagina can be used for a little bit of a longer period of time because it definitely has a slightly lower risk for developing cancers. So essentially every single scenario is different, and a really good healthcare provider will take your clinical situation and treat your clinical situation as opposed to the same medication for every person. So these are just very common products that you may have heard of through your healthcare provider, and talking about dosing. These are sort of, just more clinical slides. So I want to get into some of the questions that you might have, but these are products that you might see. I use these slides oftentimes with my students when I'm teaching them like how to prescribe and what to prescribe. So here are some alternatives to hormone therapy, right? We know that certain antidepressants, things like Prozac, Zoloft, Effexor, Paxil, can be really helpful at preventing hot flashes. And we found that out through studies that we were treating women with those medications for depression. And we found out like that population isn't really complaining of hot flashes. So a lot of times those medications are used off label for the treatment of hot flashes and can be very, very, very effective. So if you have a reason why you can't use hormones or estrogen, this is a viable option. There's also medications called gabapentin or Neurontin, which is also extraordinarily helpful to prevent hot flashes. So even if you cannot use estrogen therapy for whatever reason, mom had breast cancer, you had breast cancer, you've had a history of another estrogen dependent cancer, there are other alternatives for you. So, these are things that you might want to talk to your healthcare provider about. So, important conversations to have. And then there's complementary therapy. So things like soy, which, doesn't hold as much evidence that it's helpful, although I have patients that use soy products, a lot of tofu in their diet, and they say that their hot flashes improve. So, is it something that I kind of, poo-poo? I don't. I just feel like whatever works. Traditional Chinese medicine, and there are, many practitioners in the area, can be very helpful for hot flashes and some of the menopausal symptoms. Even acupuncture has some pretty good data for treating menopausal symptoms. So it's something that you might want to think about. Certain herbs, black cohosh, cranberry, St. John's wort, valerian, vitex, those are all, herbs that are oftentimes very helpful with postmenopausal and menopausal symptoms. And then here it is, guys. This is what you don't want to hear, right? And I'm going to end this shortly, but I want you to hear it, right? Relaxation techniques, do the work, exercise, yoga, meditation, hot flash triggers, those things we talked about earlier, caffeine, alcohol, spicy foods. Dress in layers so that we can take layers off when we get really hot. Make sure that we're drinking cooler drinks instead of hotter drinks, right? Make sure that we are, paying attention to our sexual health so that this just becomes a transition and not like, oh my God, this is the end of my life. So do we have ways to treat it? We do. So for those of you that are now post-menopause, you've already had your period gone for a couple of years now. So that transition and the time afterwards, right? This is the time where we want to really implement our lifestyle changes so that we maximize our health moving forward, because most of us have 10, 20, 30 years left ahead of us. And we want to maximize those years so that we're feeling really, really good. So again, just to kind of wind down, and I want to take your questions and I want to be respectful of your time. If you're a smoker, cut down, stop. There's nothing healthy about smoking. I know you know that. I don't need to repeat that. Minimize your alcohol use. Don't overuse alcohol. And then, watch your prescription sleep aids. Watch the medications that you're using for long periods of time. And can you incorporate any healthy lifestyle changes that may increase the chances that you can decrease the amount of medication that you have? Can you maybe come off your antihypertensive medication because you've now committed to losing weight and eating a much healthier diet? Like, most of the diseases that we have can 100% I don't want to say 100% treated, but certainly we can see a decrease in symptomatology if we start to pay attention to diet, exercise, stress management. Those three things are probably the most important things that I try to teach all of my patients. And here it is. Don't hate your partner. They're trying. So this slide I love. What do you mean how do I feel? Like you had a hell of a day with your hormones, right? Don't you feel like saying that sometimes? So just know our partners are trying. They're definitely trying to help us get through, but they don't know what they're doing either with us. So that's why we're all here, right? We're all here to try to figure out, like, how do we move forward? So, okay, it's just 8 o'clock now. If you have any questions for me, I just love this little baby slide. I think she's adorable. I want to thank you for your time. It's been a pleasure to be here with you. I'm happy to take any questions that you have.
Oh, thank you so much. That was wonderful. I wish I would have heard you a few years ago, but this is wonderful. Um, so a couple questions, if that's okay. So somebody is asking, a lot of people are saying, thank you, this is wonderful. Okay, hold on just a second. I'm going. Okay, so you did mention tofu and soy as a protein, so that's good. That's great. So someone said it regarding painful intercourse. What do you think about probiotics for that? Is there any truth to that, or?
Yeah, so probiotics are helpful to prevent, again, some of the discomfort that women feel with urinary tract infection. They're not necessarily, and there's as far as I know, and I had, certainly I'm guilty of not always reading, the most this month's journals, but
Mhm.
probiotics are helpful to prevent against urinary tract infections, bacterial infections, and yeast infections in the vagina. But are they going to actually help with the elasticity in the vagina that helps to prevent against painful intercourse? They're not. So that's a different conversation altogether with your healthcare provider. And some of those products I mentioned earlier, from that hellobonafide.com, and vaginal estrogen therapy can be really helpful for the actual painful intercourse. But probiotics, just to prevent infections, not so much for painful intercourse. It's a great question.
Thank you so much. Also, what are your thoughts on joint pain and perimenopause,
Yeah.
menopause?
Absolutely. So as your estrogen levels decrease, joint pain actually increases. So it is one of the things that many of my colleagues and I see in patients on a regular basis. Sometimes joint pain, again, multifactorial. Is there a need to lose weight? Right, losing weight oftentimes can sometimes help with joint pain. We're carrying around more weight that can impact our level of pain that we have in our joints. Oftentimes, if it's significant joint pain, I'll usually use some of the anti-inflammatory supplements. And again, every case is different, so I would tell you to talk to your provider about this. But things like curcumin or turmeric can be very helpful for joint pain. Fish oil can be very helpful for joint pain if you're somebody that can take those products. And sometimes it does require a little bit of hormone replacement. It just kind of depends on the clinical situation. But if you're able to take fish oil, if you're able to use curcumin or turmeric, I like Gaia Herbs. It's an easy supplement to get over the counter. You can get it online at Amazon. Gaia Herbs, Turmeric Supreme or Curcumin Supreme. It's one. The label says one of those two. That can be a great supplement to help with joint pain. So anything that's going to decrease inflammation in your body will generally help with joint pain. That anti-inflammatory diet is excellent for joint pain.
Great. Just a couple more or one more. Do hormone therapies, to your knowledge, help with weight loss, especially belly loss?
It's a great question. So there's Uh, so hormone, this, I get this question all the time, because this is so many women come to see me for this specifically. So, losing, gaining weight is pretty much, it pretty much comes with the territory. So will hormone replacement therapy help people to lose weight? It's not going to be like an appetite suppressant. Like, it was not going to be like a pill that all of a sudden the weight's going to fall off. But if you're somebody who exercises regularly and puts in the time and effort, can hormone therapy actually help you maintain your weight, and take it off if there's been some weight gain? It can, but it's not the magic pill, right? The exercise and the diet still has to be there. So the work still has to be done. But as we, each decade of our life, and this is important to know, ladies, if you're listening still, every decade of your life, your metabolic demands decrease. So if you eat the same amount of calories every day, your entire life, past age 30, you will start to gain weight. So every decade, you need to either decrease your caloric intake by 10% or increase your activity by 10% just to maintain your weight. And that is true in effect to what's happening with our hormones. So think about that. Just to maintain your weight, you have to either eat 10% less or exercise 10% more. To lose weight, you might have to do both. Right. So the hormonal piece, I will say to people, the work still has to be done. You can't just live life as normal and think that hormones are going to take weight off. But it can make it a little bit easier sometimes.
Oh, us poor women, what we go through
Oh gosh, I know. I
from
know.
day one, right?
I know.
Oh, thank you so much. This was just wonderful, so
Excellent.
interesting and comprehensive, and thank you really
Of
very much.
course.